Today, we'll discuss about organophosphate poisoning. Organophosphates are chemical compounds formed through esterification between phosphoric acid and alcohol. They can be divided into dimethyl organophosphates and diethyl organophosphates. These are the examples. Organophosphates are commonly used as pesticides, herbicides, and sometimes used as nerve agent in the chemical warfare as well. The most commonly used organophosphate pesticides include parathine, chlorpyrifos, dichlorobos, as well as malathion and other compounds. So how does poisoning occur? Poisoning occurs through the deliberate poisoning or through the accidental exposure or during occupational exposure in farmers and during chemical warfare and terrorist attacks. OP can enter into the human body through inhalation, ingestion, contact with the skin, or ocular contact. So now talking about the pathophysiology, normally when acetylcholine is released into the synapse, this acetylcholinesterase enzyme breaks acetylcholine into choline and acetate, and some of the acetylcholine acts on the receptors and shows its normal action. But in case of the OP, when this acetylcholinesterase enzyme is inhibited by the organophosphate compounds, this acetylcholine in the synapse cannot be broken down into the choline and acetate. So there will be surplus of the acetylcholine in the synapse, leading to the overstimulation of the receptors, nicotinic and the muscarinic receptors. This picture shows stimulation of the nicotinic and muscarinic receptors by acetylcholine, which occurs in excess amount in cases of the organophosphate poisoning, leading to the various symptoms. To understand the mechanism of the organophosphate poisoning, we need to know about the organophosphate aging. It is a process of chemical stabilization of phosphate bond to acetylcholinesterase that occurs over time. So when this phosphate bond stabilizes, this acetylcholinesterase cannot be regenerated. This is important because during the treatment, if we prescribe the palm before the aging initiates, this acetylcholinesterase enzyme can be regenerated. For the diagnosis, history and physical is very important. We need to ask about the specific compound involved, timing of the exposure, amount of the poison taken, type of exposure, and onset of the symptoms. Similarly, in this physical examination, we can find a garlic or solvent odor, which is a typical characteristic odor of organophosphates. The patient usually present with a cholinergic toxidrome, and there can be muscarinic symptoms which can be easily remembered using the mnemonic dumbbells. And it includes defecation, diaphoresis, urination, meiosis, bronchospasm, bronchoria, emesis, lacrimation, salivation. Similarly, patient can have nicotinic symptoms, and we can remember this by using the mnemonic days of the week. Mydriasis, tachycardia, weakness, hypertension, fasciculations, seizure, somnolence are the nicotinic signs. There can be other findings because of the nervous system involvement. There can be anxiety, confusion, drowsiness, seizure, hallucinations, headaches, insomnia, circulatory and respiratory depression. Sometimes patient can present with intermediate syndrome. It usually occurs 24 to 48 hours after the onset of organophosphate poisoning and after the cholinergic crisis has ended. Patient usually presents with muscle weakness, respiratory failure without cholinergic signs, and the fasciculation. So it's basically characterized by the proximal muscle weakness, cranial nerve palsy, and the respiratory failure. This can persist for several weeks, and most of the patients, they usually make slow recovery. So next manifestation of the organophosphate poisoning is organophosphate-induced delayed neuropathy. It develops days to week after the acute toxicity, and it's more frequent with the compounds like chlorpyrifos, dichlorobos. And this neuropathy arises due to the inhibition of the neuropathy target esterase enzyme, which catalyzes the breakdown of major phospholipid within cell membranes in nervous tissues. Patients, they usually present with the muscle cramping in the lower extremities, distal numbness, paresthesias, and loss of the deep tendon reflexes. Usually, the diagnosis of OP is relies on the clinical evaluation. Initiating treatment before laboratory confirmation is very important. High degree of clinical suspicion is very important, and patient must commonly present with the symptoms of myotic pupils, diaphoresis, and the respiratory distress. There can be distinctive garlic or petroleum odor. We can do the atropine challenge test. This test is usually done when OP is a differential diagnosis, but it's not confirmed. So if the symptoms improve following the administration of 0.6 to 1 mg atropine, that raises the suspicion of AC inhibitor poisoning or organophosphate poisoning. However, in case of the significant poisoning, patient may not exhibit any response to a small dose of atropine, which can result in the false negative test. Next test which we can do for the diagnosis is cholinesterase activity. It can be tested in as butyryl cholinesterase activity and RBC acetylcholinesterase activity. RBC acetylcholinesterase activity has strong correlation with the clinical features of organophosphate toxicity. And the symptoms typically develop when more than 50% of the RBC acetylcholinesterase activity is inhibited. Other tests include CBP, CMP, liver function test, renal function test, glucose level, arterial blood gas analysis, pregnancy, and ECG. So, talking about the treatment, first of all, the healthcare personnel should wear proper PPE to protect themselves from the poison. After that, decontamination can be done, which include washing the patient's skin thoroughly with soap and water 3 times, removing all the clothing worn by the patient. And what we need to understand is decontamination should not delay the timely medical intervention for a patient in severe distress. Airway control is important. Intubation might be required due to bronchospasm, seizure, or bronchorrhea. IV access is important. Cardiac monitoring should be done. Atropine is the primary treatment for organophosphate poisoning. It competes with acetylcholine at the muscarinic receptors. Usually, it is given IV in as an initial dose of 2 to 5 mg for adults. And if patient doesn't respond to the treatment, the dose is doubled every 3 to 5 minutes until the respiratory secretions have cleared and there is no bronchoconstriction. At this point, the state of atropination is achieved, which is characterized by the appearance of the anticholinergic signs and symptoms in the patient, including dry skin and mucosa, decreased bowel sounds, tachycardia, no bronchospasm, reduced secretions, and the pupil dilatation. So the main objective of using atropine is to improve the cardiorespiratory parameters in patients dealing with OP toxicity. While using atropine, patients should be monitored for heart rate, blood pressure, respiratory status, pupil size, and skin moisture. Some patients might require atropine over the course of the several days to week, and atropine doesn't mitigate the nicotinic effects. So patients should be closely monitored for the development of the neuromuscular junction dysfunction or respiratory failure. Next medication for the OP poisoning is pralidoxime or PAM. This drug reactivates the phosphorylated acetylcholinesterase by binding with the organophosphate, but it must be administered before aging, because if it's administered after aging, it will not be effective to reactivate this enzyme, acetylcholinesterase. It's always used in conjunction with atropine, and the dose is bolus is given at least 30 mg per kg for adults. This drug should not be administered rapidly because it can lead to cardiac arrest. And after the initial bolus, a continuous infusion of the medication at the rate of at least 8 mg per kg per hour for adults should be continued, and this may be required for the several days. So this PAM, it binds with the organophosphate and helps in the regeneration of the acetylcholinesterase. This is the mechanism of the PAM. For the seizures, benzodiazepines can be used. There is limited data regarding the effectiveness of the ECMO, hemodialysis, or hemoperfusion. In few studies, magnesium sulfate has shown benefit in managing the patients of organophosphate toxicity. And in certain cases, if patient is not responding to the atropine, epinephrine can also be used for the treatment of organophosphate poisoning. So when there is suspected or confirmed organophosphate poisoning, first 3 to 5 ampoules of the atropine should be given by IV bolus. At the same time, pralidoxime should be started. A risk assessment should be done. And if patient is agitated, diazepam can be given. If there is seizure, again, the diazepam can be used. After 5 minutes of giving the atropine, again, a patient should be evaluated for breath sound, systolic BP, heart rate, sweating, and pupil size. And the target after giving the atropine is clear chest and auscultation, systolic BP more than 80, heart rate more than 80, plus minus dry skin. So if there is no improvement after giving the initial atropine, the dose of the atropine should be doubled. And if there is improvement, we can use the similar or the small doses. And once the target is achieved, we can start the infusion of atropine at the dose of 10 to 20% of the total required dose every hour. And during the continuous infusion of atropine and PAM, patients should be monitored for heart rate, systolic BP, respiratory functions every 15 minutes. And patients should be carefully observed for the intermediate syndrome and the recurrent cholinergic symptoms or atropine toxicity. So in addition to the atropine, PAM should also be continued in the infusion until there is clinical improvement. Complications include intermediate syndrome, organophosphate-induced delayed neuropathy, and the neuropsychiatric deficits like confusion, memory impairment, lethargy, psychosis, irritability, and Parkinson-like symptoms. The differential diagnosis is broad and might include gastroenteritis, myasthenia gravis, Lambert-Eaton syndrome, botulism, nicotine poisoning, carbamate toxicity, and other toxicity like neostigmine toxicity, pyrrhotostigmine toxicity. Mortality rate is usually 2 to 25%, and the mortality is most frequently associated with dichlorobus, malathion, dichlorophon. And the leading cause of death is the respiratory failure resulting from the bronchoria, bronchospasm, central respiratory depression, and weakness or paralysis of the respiratory muscles. So, to identify the poor prognosis, we can use this POP score or Peradenia organophosphorus poisoning scale. It's a validated tool to assess the clinical severity and determine the prognosis. If the POP score is 0 to 3, poisoning is considered to be mild. If it's 4 to 7, it's moderate. And if it's 8 to 11, it's considered as severe poisoning. POP score uses these parameters, which include pupil, respiratory rate, heart rate, fasciculations, level of consciousness, and presence of seizure. So all the patients should be admitted to the hospital and they should be closely monitored for minimum of 48 hours within an ICU setting. If patient remain asymptomatic for the 12 hours, they can be considered for the discharge. And during discharge, patients should be educated regarding the appropriate storage and handling of the organophosphates, and psychiatric consultation is required for the intentional poisoning. Thank you so much for watching. Please subscribe to our channel for more videos.